It seems we've hit the hour. Today's summer session presenter will be Hélène Cote and her laboratory. I have two announcements before I introduce Hélène. The first is that the CBR LSI Research Day, August 14th, remember, put it in your calendars if it's not already there. Registration is open, so register quickly because our organizers are anticipating lots of good food and we want to make sure that it's well provided for. And November 6th is the Earl Davy Symposium. So please put those in your calendar. Hélène is really a long supporter of the Center for Blood Research, even well before its inception. She was a graduate student in the founding Center for Blood Research directors, Ross McGilvery, his laboratory. And then she went south of the border to do a postdoctoral fellowship in the laboratory of Earl Davy, whose symposium you're going to be going to. So she has, like I said, been a supporter of the Center for Blood Research for a long time. Then she came back north to continue her training in the Centers of Excellence in HIV and AIDS, where she continued her training in molecular biology, applying her skills at that center, and where she subsequently obtained a professorship in pathology and laboratory medicine, and she has done so much for this department, including director of the graduate program. And for that, we thank you. And I'll leave it up to you to introduce your laboratory. Thanks for joining us, Hélène. Are you going to be using this microphone? Have you got a different one?
No, I use that one.
Okay, thank you.
Thank you, Ed. Yeah, very nice to be presenting to you today, and yeah, long time known head. So our group is mostly interested in research pertaining to HIV and aging, particularly how it affects women or females. I'll say a word about that in a moment. First, I'd like to acknowledge that our research, most of it anyway, has taken place on the traditional unceded territories of the Coast Salish people. And this includes the Tsleil-Waututh, the Squamish, and the Musqueam. And how do I make this a little brighter? Because I can't see much. Sorry. Thank you. All right. Another small note before we get going is that in this presentation, we will be referring to women and also females. And so, of course, women would be a gender, females would be a sex, but there will be some interchangeability going on. And so we will use women to describe people who were assigned female sex at birth and are cisgendered women. However, we do acknowledge that not all people who were born with a uterus identify as women, and that not all those who identify as women were born with a uterus. So today I was planning on doing a brief introduction of two cohorts that we work closely with in our lab, the CARMA cohort and the BCC3 cohort. I will then give you just a general overview of the life expectancy of women living with HIV, especially in BC. A brief overview of some of the projects that are ongoing in our lab, and then we will have three of my trainees who will be each making a short presentation: Lulu Kai, Juliette Zama, and Monika Kovac. So the cohorts, CARMA stands for Children and Women and Antiretroviral Therapy and Mechanisms and Markers of Aging, and BCC3 is really the British Columbia CARMA CHIWOS collaboration. BCC3 came about when CARMA ended. It joined force with another cohort, a Canadian cohort called CHIWOS, that was mostly looking at sexual and reproductive health in women living with HIV in Canada. And they were collecting a lot of social and psychosocial data. We were collecting more clinical data. They were community-based research. We were regular research. So anyway, and we had controls not living with HIV. They did not. So we took all the best elements of each cohort and brought it together to make the BCC3. So while Karma went on for 10 years, BCC3 started in 2020 and managed to enroll during COVID over 400 women, and to this day now we are over 600. So the participants that were enrolled in each cohort were a bit different. Karma enrolled male and female living with and without HIV of all ages. And it also enrolled children who were born to women living with HIV. Therefore, we call them HIV exposed, uninfected. And they're uninfected because their mother was treated with antiretroviral during pregnancy, which prevented vertical transmission. BCC3 only enrolls women, both cis and trans, that are age 16 and above. In terms of the specimen collected for research, in Karma, we were collecting mostly blood and buccal swabs, and we would process the blood into a variety of specimens that we use for research, plasma, PBMC, etc. BCC3 collects the same specimen, but in addition, we collect hair specimen close to the scalp to do cortisol measurements. And we also collect rectal and vaginal swab. These are optionals, but most participants accept. And this is to, in the future, do some microbiome studies. In terms of other data collected, Karma collected the usual demographics, anthropometrics, medical history, substance use history, fairly detailed. And again, BCC3 collects all the same things, but in addition, a lot more data on psychosocial determinants of health, mental health, stigma, housing, and racism. And I mentioned earlier, or I wrote this, like BCC3 is a community-based research study. And this means that we employ part-time several women living with HIV, whom we call community research associates. And they are involved in all aspects of the study, from the design of the survey and the questions that we're going to address. They are part of our meetings, our regular meetings. They come with us to conferences to co-present, and they are co-authors on our manuscripts. And a typical visit for BCC3 starts in the clinic with a research coordinator doing clinical data collection, and it is followed by what we call a community visit that is entirely done by the community research associates, and usually online, and where a lot of the more social data are collected. While Karma counts well over 1,000 participants, BCC3 has a target of 750, and I believe we're close to, I say 650 here, sorry, it has a target of 700, 350 women living with HIV, 350 women not living with HIV. And in both cohorts, we go to great lengths to make, to ensure that we recruit control participants who share social demographic characteristics with our participants living with HIV, so that we are comparing people who are comparable apart from their HIV. So in terms of the lifespan of women, I wanted to point out that, I'm sure you're aware, throughout the world, females, on average, have a longer life than males. That's even true in the animal kingdom, where for most mammal and most animal, females live a bit longer than males. And on this graph, you can see on the y-axis, the life expectancy of female, on the x-axis, the life expectancy of males, and the blue dotted line is where all these dots would lie if it was an equal life expectancy. So because they're all above, you can see women are living longer. And you, I'm sure, are looking for Canada, and it was not there, so I added it here. In Canada, women live on average about 4.4 years longer than males. Now, in women living with HIV, it's not true. They have a shorter life expectancy than males living with HIV, than males not living with HIV, and then females not living with HIV. They have the shortest life expectancy. And this is in the face of most people living with HIV having a longer life thanks to antiretrovirals who are allowing the virus to go undetectable. And so despite that, in women living with HIV, it's been consistently observed that their life expectancy, and I'm presenting data on life expectancy, but it's also true of their health span, really, is slightly shorter than males. So on the top right, you see a graph of data generated by Bob Hogg's group in BC and recently published in the Lancet Public Health. They looked at 3 periods of time, so 96 to 2001, 2002, 2011, and 2012 to 20. In each of those periods, whether it was people in their 20s, at 40 or at 55, women consistently had a shorter life expectancy in green than their male counterparts in blue. And the bottom graph shows you the gap between this life expectancy for the two. And as you can see, except with the exception of a short period in the mid 2000 where women did better, generally they don't. This gap is not improving. In fact, it's trending in a way that is getting even wider. And while the social demographics of those females and male may differ a little bit in BC, and the toxic drug supplies does play a role in shortening the lives of many people, it doesn't fully explain these differences. Even when they adjust for all the factors that they could, they still see this difference. So part of our goal in BCC3 is to better understand why this is, because this is what you need to know to be able to take action and promote healthy aging in this population. Moving on to some of the projects in our group. I'm not going to read them all. I'm showing you some of the ongoing work. 3 of these people are going to be speaking today, and we span a pretty broad range. We do both clinical type studies with the cohort specimen, as well as in vitro work using cell models to try and understand. Ultimately, we're trying to understand what is the role played by HIV and other viruses, what is the role played by the medication that people with HIV have to take versus everything else in their lives, which more and more we're realizing is playing a very important role. Things like not having safe housing, not having good food, not living through a lot of racism and stigma and discrimination. It's looking like it does affect your aging a great deal, including your inflammation, etc. I will leave it at that, and I will invite Lulu, who's the first speaker, to talk today.
Hi, everyone. I'm going to be speaking on one of my projects, which looks at non-HIV chronic latent viral infections and how they're associated with markers of inflammation in males, but not females. So before we dive into that, we know that there's around 66,000 people living with HIV in Canada, and the combination of HIV, antiretrovirals, and environmental factors contribute to immune activation and chronic inflammation, which may lead to that accelerated aging phenotype. In my study, I want to look at sex differences that may be associated with chronic inflammation, as well as the associations of other persistent viral infections other than HIV. So let's take a look at these other chronic latent viruses. So we have 7, and these are either chronic, so they have a continued presence lifelong, or latent, which are usually asymptomatic except for periods of reactivation. So you can think of that as like those herpes viruses where you get cold sores from time to time. So these viruses, they are more prevalent in people living with HIV compared to the controls. Common transmission routes include bodily fluids or sexual transmission. And common associations we can see on the side. So we have congenital CMV, cold sores and genital warts for herpes simplex virus 1 and 2, mononucleosis with that Epstein-Barr virus, Kaposi sarcoma with that human herpes virus 8, and severe liver disease with hepatitis B and hepatitis C. Currently, there's no really vaccine available for any of these except for hepatitis B. And importantly, all these viruses we decided to investigate because they're either one associated with another marker of immune aging, such as leukocyte telomere length, or they are associated with age-related diseases. So with that, let's look at the participants in the KARMA cohort. This is a subset of 296 participants, and they were binned based on age groups. So if we see on the left, we have equal numbers of males and females, and equal numbers of people living with HIV and those not living with HIV. And the ages span from 0 all the way to around 75. So within this demographic table, it's not where we want to highlight that we do have very purposeful recruitment in the KARMA cohort as well as the BCC3 cohort. As we see between people living with HIV and controls, there's no differences with socio-demographic data such as tobacco smoking, ethnicity, education attainment, or household income. Now let's look at the viruses that these participants have positive serology for. So on the top, we have females, and on the x-axis, we have increasing age. So with 0-ish years on the left-hand side, all the way to our 75 on the right-hand side. Each colored bar indicates a positive serology for that virus, and the viruses are ordered from least prevalent to most prevalent. So we have females on the top and males on the bottom. And just by eye, we can kind of see that females have more non-HIV viruses than males. And if we compare, there's a higher prevalence of CMV, herpes simplex virus 2 or HSV2, and HHV8 in female participants compared to male participants, even though they are not demographically different. If we do the same analysis and segregate by HIV status, we kind of see that controls on the top and people living with HIV on the bottom. And once again, by eye, we can kind of see that people living with HIV have more non-HIV viruses than the controls. And with comparisons, we see that there's a higher prevalence of CMV, HSV2, and EBV among people living with HIV compared to those not. So we took this data and we want to also investigate its association with several markers of inflammation. So in this study, we have 4 markers of inflammation. The first 3 markers are gut inflammation markers. So we have intestinal fatty acid binding protein, and this indicates enterocyte inflammation. So this will be released into the bloodstream if there's physical gut barrier damage. We have reg3 alpha, and elevated levels indicate intestinal damage. And this protein is also associated with some anti-inflammatory properties. And we have LBP, which liposaccharide binding protein that binds the LPS component of gram-negative bacteria, facilitating the recognition by the immune system. And finally, we have a general marker of inflammation. This is soluble CD163, and it's a marker of macrophage activation, and it's a marker of chronic inflammation. So we measured these 4 markers in our sample of 296 participants using a mesoscale discovery. So first, we look at the data with comparing the 2 sexes, males and females. And we see across the board, female sex is univariately associated with a decreased level of gut inflammation markers, as well as soluble CD163. Now, if we compare HIV and inflammation, we see that HIV itself is actually only associated with increased levels of IFAP and none of the other markers that were measured. Now, if you remember those viruses, if we look at just the absolute number of viruses, not what type, we can see that with an increasing number of viruses, there's an increased level of IFAB, REC3 alpha, and soluble CD163, but not LBP. Now, I mentioned before that I was really interested in looking at sex differences. So I took this data and I segregated by the two sexes. And here we see that in female sex, an increasing number of viruses is actually not associated with an increased level of inflammation. But if we look at the data in males, in this sex segregated analysis, we see that it is only in males that an increasing number of non-HIV viruses is associated with increased levels of inflammation in all 4 markers that were measured. Now, if we look at the age graph or this multivariable data plot, so we have that marker of inflammation on the y-axis, we have age on the x-axis, the colored bubbles indicate male or female sex, and the bubble size indicates the total number of non-HIV viruses. So if we look at the first row value, we see that, yes, age is associated with an increased level of inflammation. But if we segregate by the two sexes, we see that female sex is not associated with an increased level of female sex. Increasing age in female sex is not associated with an increased level of IFAB, whereas it is strongly associated in male sex. We see a similar pattern with REC3 alpha. However, in female sex, it's weakly. Age is weakly associated with an increase in REC3 alpha, but male sex is strongly associated. In our LBP, we see the similar trend as the first marker, as well as a similar trend in the soluble CD163. So overall, increasing age is associated with increased levels of all inflammation markers in males, but only REC3 alpha in females. Now, I wanted to look at potential associations and potential independent associations with all the viruses that we were looking at individually. So here we have a multivariable model and for IFAB, and anything on the left-hand side, there's a association with a decrease, and anything on the right-hand side, there's an increased association. So we see that female sex is independently associated with lower levels of IFAB when controlling for all the other variables listed in this model. We say that positive or people living with HIV is associated with a higher level of IFAB. And we have a sex and age interaction term, which means that we saw that kind of in the graph before, where male sex and increasing age is associated with an increased level of inflammation, but not in female sex, indicating that there's 2 different slopes kind of present for male sex and female sex when we're looking at those associations. Finally, we see that HHV8 is actually associated with a slight decrease in IFAB. Now, if we look at our next marker, we see similar trends for female sex, the sex interaction term, age. However, we see that CMV is independently associated with elevated levels of REC3 alpha. If we look at LBP, we see that female sex is once again independently associated with a lower level. Increasing age is associated with a higher level, and we still see that sex and age interaction. And finally, in soluble CD163, we see the similar trends with sex and age. However, we also see that CMV and HCV are independently associated with an increased level of soluble CD163. So this is a summary of those independent associations that we saw in our models, where female sex is across the board associated with a lower level of all the gut inflammation markers, as well as the marker of general inflammation. Increasing age is associated with higher levels of inflammation. HIV is only associated with an increased level of IFABP. HHV8 is associated with a decreased level of IFABP, and CMV is associated with increased levels of CD163 and REC3 alpha. So overall, despite females having more viruses or more non-HIV viruses than male participants, they have lower levels of all inflammatory markers measured. So, and an increasing number of non-HIV viruses is associated with greater levels of inflammation in males, but not females, as we saw before. However, although our study can't measure the direct health impact of these viruses, it highlights the necessity for sex-segregated analysis because sometimes we can make blanket statements of, oh, age is associated with an increase in levels of inflammation, but this may not be true in both sexes, where potentially a lot of studies were only conducted in males. And with that, I will pass it on to Juliet.
Okay, hi everyone. Today I'm going to be talking on my project titled The Effects of Clearing Hepatitis C Virus on Leukocyte Telomere Length Among Women Living with HIV. So a brief introduction into what HIV and HCV viral infections are. So HIV is a virus that affects the immune systems of individuals by targeting and destroying their CD4 T cells. So over time, without therapy, the immune system weakens and the individuals become prone to different opportunistic infections and eventually leading to a condition known as AIDS. But thanks to antiretroviral therapy, people living with HIV now have longer lifespans and decreased mortality. So it is estimated that about 40 million people worldwide are infected with HIV, and in Canada, its prevalence stands at about 66,000. Its major routes of transmission include intravenous drug use, sexual contact with an infected person, or vertical transmission through pregnancy, childbirth, and breastfeeding. On the other hand, hepatitis C virus infection simply has to do with inflammation of the liver caused by the hepatitis C virus. Now, infection could be either acute or chronic. In acute HCV infection, the virus clears spontaneously within a period of 6 months, whereas in chronic HCV infection, the virus persists for more than 6 months, but can be completely eradicated by use of direct-acting antiviral therapy. But when left untreated, it has the potential to progress to liver cirrhosis and eventually liver cancer. Its estimated prevalence worldwide is at about 50 million, and in Canada, it stands at about 204,000. Now, because of similar routes of transmission between HIV and HCV, about 15 to 20% of people living with HIV are also co-infected with HCV. And in these persons, HIV disease progression and HCV disease progression is faster. So let's now move on to the concept of premature aging and telomere shortening. So as we've already heard, HIV causes immune activation and inflammation. Now, with the presence of another virus such as HCV, the level of immune activation and inflammation further increases and eventually leads to immune exhaustion and immune senescence. So over time, senescent cells present with different forms of damage, and one of which is telomere shortening. So telomeres are simply short repetitive DNA sequences that are found at the ends of chromosomes and protect our DNA from damage. So you can think of them like the plastic caps that are found at the ends of our shoelaces that protects them from fraying. So do our telomeres. So the more a cell divides, the shorter its telomere becomes until it reaches a point where the cell can no longer divide and eventually leads to what is known as premature aging, which occurs in people living with HIV, where they tend to present with age-related diseases such as liver diseases, cardiovascular diseases, neurological disorders, and kidney dysfunction earlier in life than they normally would. And research, as we've already heard, has shown that women living with HIV tend to age more than men living with HIV, and consequently having shorter lifespans. So the question now becomes, does clearing HCV make any difference? And that brings me to the goal of my project, which is to evaluate the effects of hepatitis C virus clearance on leukocyte telomere length in women living with HIV. And for this project, we do hypothesize that successful HCV clearance will be associated with a slower loss of LTL. So this is a longitudinal study where we selected women from the KARMA and BCC3 cohorts. We selected women aged 16 years and above, having both viruses, HIV and HCV, and having at least 2 visits between both cohorts at baseline and follow-up. And these visits needed to be at least 1 year apart with biospecimens available for the selected visits. So we did assess 354 women living with HIV from the KARMA and BCC3 cohorts for eligibility. We excluded women who had only one visit. We excluded women with no history of HCV infection, excluded women with no available bowel specimens, and women who already cleared HCV prior to being enrolled in the cohort. And we were left with 62 women living with both HIV and HCV, having more than one visit that was at least 1 year apart, and bowel specimens available for these selected visits. So next, using plasma, we did extract viral RNA and proceeded to qualitatively detect the presence of HCV RNA by qPCR. We then divided the participants into two main groups, the HCV clearance and the chronic HCV group. The HCV clearance group has to do with women living with HIV and HCV at baseline and at follow-up clearing HCV. And for this group, we had 15 women. While for the chronic HCV group, it has to do with women living with HIV and HCV at baseline and at follow-up still having HCV. And for this group, we had 12 women. We then proceeded to match these participants based on their ages at visits, the time between visits, and their ethnicities as best as we possibly could. Next, using whole blood, we did extract DNA and proceeded to quantitatively measure leukocyte telomere length by qPCR, which is reported as relative leukocyte telomere length because it is a ratio of telomere DNA to albumin. So the table here shows demographic characteristics of our participants from baseline to follow-up between both groups. So we see that there's no significant difference in age, in time between visits, or BMI. And we also do notice that most of the participants were either white or indigenous. Now, the line graph here shows paired comparisons of relative leukocyte telomere length for the HCV clearance and the chronic group. So the x-axis represents the timeline from baseline to follow-up, and the y-axis represents the relative leukocyte telomere length. So we do see that in both groups, there is no significant difference in LTL from baseline to follow-up. And we do suppose that this could be due to the overriding effects of HIV on telomere length, or also due to the limited follow-up time which we did have in our study that doesn't allow us to detect any significant differences. Next, we did look at the mean relative leukocyte telomere length between both groups. So similarly, the x-axis represents the timeline from baseline to follow-up, and the y-axis represents relative leukocyte telomere length. Red stands for the HCV clearance group, and blue for the chronic HCV group. So we do see that at baseline, there is no significant difference in mean LTL between both groups as all participants have HCV. Likewise, at follow-up, there is no significant difference in LTL between both groups, but we do note a slight increase in telomere length for the chronic group as opposed to the clearance group, which somehow opposes our hypothesis of slower leukocyte telomere loss in the clearance group. Now, we do suppose that this could be due to immune exhaustion or immune system homeostasis, where in the chronic group, there is less proliferation of immune cells, and consequently, the telomere lengths appear shorter as opposed to the clearance group, where the immune cells are actively dividing as it gets rid of the infection. And also due to our limited sample size, that doesn't allow us to detect possible differences. So conclusively, for this, our preliminary study, we do see that there was no effect of telomere length changes in women living with HIV despite their HCV status. And moving on, we plan on collaborating with the Canadian co-infection cohort to increase our sample size. We would include control groups, look at other markers of aging and inflammation, and also look at possible confounding variables. I'll be calling on Monica to continue.
Okay, so now that we've had Mike's over here. Now that we've had a great introduction to inflammation, to HIV, HCV, and the liver, I'm going to dive a little bit further in, talking about factors affecting liver fibrosis among women within the BCC3 and KARMA studies. So first, I want to take a bit of a step back and introduce hormones into this equation. So ovarian function is critical for women's health. Ovarian sex hormones, that is our estrogens and our progesterone, fluctuate throughout life, but are protective to many body systems, including bone, heart, and liver, which I'll be talking about today. Now on the slide here, you see a rough graph giving you the way that these hormones fluctuate throughout life. So we see them starting to rise, both our estrogens and progesterone in puberty. They are highest during the menstruating or reproductive years. Now I do want to note that the cycling of the menstrual cycle is not depicted in this figure. It's just a flat line. They begin to then fall in perimenopause and are the lowest after menopause onset. Now, this leads me to a concept called amenorrhea. Now, amenorrhea is more than 1 year without menstruation during those normal menstruating years. Women living with HIV within British Columbia were found to be more likely to experience this prolonged amenorrhea for reasons unrelated to pregnancy, lactation, contraception, surgery, or menopause. Prolonged amenorrhea has also been associated with lower ovarian hormone levels, those protective hormones. Now, what about the liver? Low ovarian hormone levels have been associated with accelerated liver fibrosis. So this leads to the question, does abnormal ovarian function place women at higher risk for liver disease? So we aimed to examine the potential associations between a history of abnormal ovarian function and liver disease in women living with and without HIV. So putting that whole info slide of words there into a picture for you, we know from the literature that low ovarian hormones are seen with people experiencing amenorrhea, that lack of menstruation for at least a year, and affect our liver health. The question we are trying to address is whether there is this link between these lower hormones, this amenorrhea-like state, and liver health. So the cohorts and the samples for this study come from both CARMA and BCC3, and as of our data download date of November 2024, that gave us 1,196 possible unique individuals, so not replicated individuals. 357 were then excluded due to an age of less than 16 years or assigned male sex at birth. That left us with 821 possible participants, and then 257 were further excluded because they were missing data on reproductive health, HIV serostatus, or the variables needed to calculate our liver disease FIB4 index. That leaves us with 564 individuals or women, which is what the data that is presented on today comes from. So how did we define liver disease? This is a FIB4 index, or liver disease fibrosis. This is based on two different enzymes, AST and ALT. AST is aspartate aminotransferase, ALT being alanine aminotransferase. These are liver enzymes that can be released into your blood following liver damage. And we get this FIB4 index by using the equation on the slide there, which is age by our AST over the platelet count times the square root of the ALT. These values were then categorized based on clinical parameters into low, so less than 1.3, intermediate between 1.3 and 2.67, and high above 2.67. History of abnormal ovarian function was designed as having that history of prolonged amenorrhea, that at least a year or 12 months of no menstruation, premature ovarian insufficiency. This is biochemically confirmed, so using follicle stimulating hormone or FSH, menopause at less than 40 years, early menopause, so menopause at less than 45 years. And notably for this analysis, individuals diagnosed with polycystic ovarian syndrome or PCOS were excluded. From that, we segregated our analysis according to HCV seropositivity. Now this is for two reasons. Opioid use is known to influence amenorrhea. So we want to account for this when we're talking about history of abnormal ovarian function. And in our cohort, opioid use and HCV were highly collinear, so we could not put them together in a model. So we had to segregate based on HIV serostatus, so we could include opioid use when trying to understand history of abnormal ovarian function. That brings us to a very, very busy slide. So bear with me here as I talk you through it. So this is the demographics and the variables that were included in our multivariate model. It is subdivided into our HCV seropositive participants, which is on your left-hand side. Right? Did I get that one right? Okay, it's on your left-hand side, and HCV seronegative participants on your right. Each of these are divided into the women without HIV, that first column, and the women living with HIV. Now, what we see is that in both our HCV seropositive and seronegative participants, women living with HIV had higher levels of FIB4 than women without HIV. The only other one that is significantly different within our groups here is actually within our HCV seronegative participants. At the very bottom, our body mass index or our BMI with a slightly higher 27 compared to 25 BMI in our women living with HIV compared to without HIV. But I do want to talk you through some of these other variables that we see here. First one I want to talk about is ethnicity. Now you see ethnicity is presented to you two different ways. It was entered into our multivariate model as white versus racialized, and it is used as a surrogate marker of racism within the healthcare system. So about a woman being less likely to present earlier for a diagnosis and therefore potentially having higher FIB4 index. We have also expanded that into our categories of Indigenous, ACB, and other for those that are interested in who makes up this category, but based on our numbers, we were not able to input this as separate lines within our analysis. I also want to talk about our opioid use and smoking. So while these are not different between our groups, they are much higher within our cohort compared to the general Canadian population. So we can see in our HCV seropositive participants, our opioid use was 80% in our women without HIV versus 73% within our women living with HIV in our HCV seropositive, and then it is 21% and 13% respectively in our HCV seronegative participants. Now this is higher than the general population, which looks at 1% illicit and 16% prescription use. Same story is true with our smoking, 91 and 86% within our HCV seropositive participants and 42 versus 46% in our HCV seronegative compared to the Canadian statistic of 10%. So this is a cohort that is unique, and that's part of what both Lulu and Juliet discussed, where it is a balanced cohort where we are looking at similar sociodemographics, but it is still important for health. So univariately, what do we see? Well, we see when we look at living with HIV, we have our HCV seropositive participants closest to our y-axis and the HCV seronegative on the other side. Our women living with HIV are in pink, and our women not living with HIV, or our control women, are in gray there. And we do see that living with HIV is associated with a higher FIB4 index. That is true for HCV seropositive participants and trends with our HCV seronegative participants. However, we do not see a difference in abnormal ovarian function between our groups. Now here we still have HCV seropositive on the closest to the y-axis and HCV seronegative closest to the further side there. Pink is still women living with HIV, gray is still women not living with HIV. However, we are now divided in yes and no, experiencing or did not experience a history of abnormal ovarian function. I talked about a multivariate model, how we put all of these things in together. So here we see our multivariate models for HCV seropositive participants, again, closest to the y-axis, and HCV seronegative participants further from that y-axis here. Our two outcomes of interest are in boxes. So our orange box at the top gives us living with HIV, and we see in both our HCV seropositive and seronegative participants, living with HIV was independently associated with a higher FIB4 index, whereas history of abnormal ovarian function was not associated with a change in FIB4 index in either group. Now we do see age has a very slight increase in FIB4 in both of our groups and BMI only in our HCV seropositive participants. So to conclude, our study aim was to examine the potential association between history of abnormal ovarian function and liver disease in women living with and without HIV within our cohorts. And we found in adjusted analysis, history of abnormal ovarian function in our cohort showed no independent association with liver fibrosis, but living with HIV did amplify liver fibrosis independent of our other variables such as older age, alcohol, and opioid use. And with that, I'm going to do the acknowledgements for all of us here. So we would all like to thank our BCC3 and CARMA participants, our community research associates who are very instrumental to our team and the questions we ask and how we present our data. The staff, research staff, that is the BC Women's Hospital Research Lab, our BCC3 partners, community advisory board members, and other Cote Lab members, some of which are listed here on the slide. Of course, we would also like to thank our funders, which is all the logos you see at the bottom. And if you're interested in our study, would like to know more about BCC3, other studies that are ongoing, or things that have already been published, or some of that community engagement and knowledge mobilization you do, please check out our website. X or Instagram are up there, and the QR code will take you to that website if you are interested as well. And with that, I will welcome my co-presenters to come back up so that I'm not alone for questions here. Thank you.
Thank you very much. Some wonderful, wonderful talks. The floor is open for some questions. Maybe students first, if not, others. Well, I've thought this idea of multi-pathogen burden has been ongoing for many, many years and really an underexploited area of investigation. I remember papers 20 years ago. One one non-viral marker that was very interesting in combination with herpes viruses was chlamydia. Do you have information on chlamydia? Because combined with cytomegalovirus, chlamydia has been linked with atherosclerosis. And I'm wondering whether this is going to be a huge variable and some sort of a factor that you'll be able to build into your studies.
Yeah, I'll answer that. So unfortunately, we don't have data on chlamydia, but we are in the process. We just got funded to continue this work, and we're going to be inviting about at least 400 of our BCC3 participants for an additional visit. So we can now add some questions to our survey. And I'd have to look more about chlamydia. These viruses are lifelong. The ones that chlamydia is not lifelong. It would get cleared. So we would need for them to know if they have a history of chlamydia, right?
Yeah, a frequent one. Yeah.
Yeah, I think we can definitely consider that. That's interesting because there's no question that cardiovascular disease is definitely higher in people living with HIV and is a big killer for the women.
Yes.
Thank you. I have a kind of naive questions. It's very interesting for the HCV and then HIV. They're kind of correlated. I'm just wondering because for HCV, usually they were kind of related to other like hepatitis virus as well. So in this cohort, are they also HBV positive or negative, or they will be excluded, or?
Which one is that?
The last one. The last
one. Okay. Because we both talked about HCV.
Yeah.
So they're not excluded, right? We don't have, so in the data I presented here, the numbers wouldn't have been high enough to put that in as a covariate, right? But we could definitely do exploratory analysis. This was done November 2024. So there are more women that have since been enrolled. The plan will be to take a look sort of once that 700 is sort of reached to see what numbers we have. So there's a chance we could do exploratory there, but the numbers are currently not high enough to be able to make a meaningful comment on that one. Which is good for the women, that the numbers are not high enough.
I was wondering if there were any interesting effects of different combinations of the viruses, Lulu, in your research, like if there are any specific combinations that had interesting effects.
So the different combinations I have been looking at, however, I didn't present, but some of what's interesting is that there's different combinations in the two different sexes that may be associated with like an increased level of inflammation or a decreased level of inflammation. So for example, that HHV8, it's kind of interesting on its own. It's independently associated with a decrease of IFAB. However, with combination with like CMV, that effect kind of decreases. We are limited by just like the number of viruses each individual has, or like the number of people who just have two viruses or just have these two viruses to compare. But I will be definitely looking at other interesting combinations for sure.
As a follow-up to that, in the past, I think a past student called Nancy Yang presented, and she too explored combination of viruses and association with telomere length. And it was an exploratory study that we have not published. It was meant to inform the next study, but we did see that some viral combination were particularly negatively associated with telomere length. Things like it was bad, and it was also, there was sex differences there too. So I think HSV and CMV was particularly not good for your telomere. And I failed to remember all the other ones. But one thing that did come out in her study as well was that HHV8 was protective for the telomere.
I have another kind of comment question. I was reminded by your graph showing life expectancy of males versus females. I was reminded of a JAMA paper that was published last year that studied a nursing cohort of female relationships versus female-male relationships that showed that the female-female relationships had a 20% lower life expectancy than the female-male relationships of the females, which of course the conclusion is that living with a female is harmful. But all laughing aside, how is this all going to figure in? That
It's a good question.
yeah, it really is. I thought that was a really interesting
I think
study.
it points to, I think our work points to the importance of biological sex, but gender is also important. And your study, I think, would point toward gender. And indeed, our last funding will allow us to really expand. And while BCC3 so far has only enrolled cis and trans women, and we only had, I think, 7 trans women, so not enough to do our analyses, but we're expanding to really enroll a much larger number of trans and gender diverse individuals. So we will have cis men, cis women, and trans women, which will really allow us to try and look at the influence of biological sex and gender identity on all these markers that we're interested in.
That's wonderful.
Thanks.
With no more questions? Oh, any online? Very good. Thanks, Jessica.
Okay, so can you comment on the influence of line 1 on inflammation in HIV patients? So line 1 is long interspace nuclear elements. And it's really a retrotransposon that has been of interest for our lab because it's an element that is similar to HIV in many ways, in that it can it's in our genome and it can travel within the genome. And so like HIV, it gets incorporated. Like HIV, it can trigger inflammation when it's present in the cell. And like HIV, it's inhibited by the medication that people living with HIV take, particularly medication belonging to the nuclear reverse transcriptase inhibitor family. And that is because both line 1 and HIV encode a reverse transcriptase that allows the DNA to they make an RNA, then they reverse transcribe this RNA into cDNA, which allows them to be reintegrated in the genome. So we are looking at line 1, and one would hypothesize that perhaps people living with HIV who are receiving these medication would have less line 1 moving around their genome, which may diminish the inflammation related to it. And that would be a first where, and it would be an advantage for people living with HIV and a protective effect of these drugs. And indeed, there's now a clinical trial going on where people are given HIV and RTI medication as an anti-aging agent because of its line 1 effect.
Any others online? No?
I don't think so.
Okay.
So
Well,
I would like to again thank Lulu, Juliette, and Monica, and thank you for your attention.
thank you.